Hi, Dr. Joy. I think you should be able to hear us. Oh, great. I can hear you too. Thank you for joining us today. Dr. Joy graduated from McMaster DeGroote School of Medicine in 2020, and then she completed her residency training in Collingwood as part of the Rural Family Medicine program from McMaster University. She really, in COVID pandemic, saw an opportunity to address the mental health crisis and really worked with Dr. Joskus to develop a mental health interview guide and a training program that could be shared with fellow family medicine residents as well as physicians and communities. So thank you, Dr. Joy, for joining us today, and we look forward to your presentation.
Thank you. Thank you for the introduction. I wish I could be there in person today, but I have my Georgian Bay map up behind me, so that was as close as I could get this morning. So yes, as Michelle introduced, I'm Jodie. I completed my residency program in the Collingwood area, which was a great opportunity. I'm so happy for that, and I continue to work in the region, currently locally as a family physician. Right now I'm in Muskoka Beach. So similar to Dr. Chisholm today, I had the opportunity to speak about an initiative that came out of the pandemic that was supported by ROMP and the Collingwood Hospital United Way. And so I hope that it will give you a little peek into this one specific initiative that focused on upskilling the skills of general providers in primary care to help meet the mental health need. So here are some of my objectives. So hopefully by the end of the presentation today, you'll be introduced to this local initiative that was created to address the gap that exists in specialist mental health care by increasing the skills of pre-existing generalist providers, and then consider how similar initiatives like the ones that Dr. Chisholm had introduced us to might align with some of our priorities in rural municipalities to strengthen our healthcare ecosystems to improve access to services for our population. So a little bit of background about how this project came about. As I said, through RUMP and the hospital, we had access through an application to the Emergency Community Support Fund to receive funding for addressing the challenges we were seeing arising with respect to mental health in the COVID pandemic. So when we sat down to think about what this project would look like, we wanted to bear in mind a few of the realities that were emerging across the nation. So the first one, as Dr. Joseph has mentioned, and the reason we're here, we obviously were seeing that mental health was taking a hit during the pandemic, to say the least. There was one study from 2021 where 38% of Canadians were reporting deteriorating mental health, and that was just after the first wave of the COVID pandemic. We were also, though, seeing that the negative consequences were not distributed evenly. We were seeing that people who faced challenges with the social determinants of health, whether that was access to food or income insecurity, were disproportionately affected by these challenges. And then when we looked locally, I'm going to sort of remind you of some of the statistics that Dr. Joskus already shared. We were seeing similar patterns. So prior to the pandemic, there was a pre-existing shortage of psychiatry care. The Canadian Psychiatric Association, as Dr. Joskus shared, endorses a 1 psychiatrist for every 800 Canadians ratio. And in Collingwood, this would indicate that there should be approximately 7 psychiatrists for the about 60,000 permanent residents serviced by the Collingwood General Marine Hospital. Right now, there's less than 2 full-time equivalent psychiatrists. That was even before we went into this, the pandemic. As Dr. Joskus shared as well, the Mental Health Response Unit, which is a combination of the Ontario Provincial Police with a social worker who specializes in mental health, we're seeing an increase in the number of calls that they were getting by 69.3% in 2020 compared to 2017, the pre-pandemic average. And then, as we heard from Dr. Chisholm, certainly an increase in emergency department volumes related to mental health. So, I'm vain and put a picture of myself here, but we were trying to bear these realities in mind and what the mental health landscape was looking like in Collingwood. So we wanted to think about how we could help meet the need for mental health care in the fallout of COVID with a shortage of local specialist care and recognizing the importance of specifically addressing the social determinants of health. And so with that in mind, the current intervention was designed. And the nature of this intervention was two-pronged. You're going to hear more about the resource guide component, I think, after me from Angela, but the two-pronged intervention was part resource directory, so accumulating an accessible document of services for mental health for adults in the South Georgia Bay region, and this was sort of the adult version of a previously created youth mental health map, which, if you haven't checked it out, is available on the Collingwood Hospital website. If you just type in youth mental health directory or map, it brings up from the Collingwood Hospital website. So that was one prong. The second prong, and the one that I was more involved in through my residency training, was a communication-focused intervention in the format of a mental health communication guide. And that guide is what we'll go into a little bit more today. But the aim was to increase the capacity of primary care providers to conduct an effective mental health interview, and to hopefully, through fallout of that, better diagnose and meet the needs of our patient population. So the communication guide really was focused for clinicians to be using. So I will give you a little closer look at this intervention. So, as I said, the theory behind the communication guide and how it might help meet local need was that it would help hopefully equip family doctors and other frontline providers in mental health care with some of the skills to optimize their mental health interview technique. And by mental health interview, I mean having a conversation with a patient during a patient encounter about their mental health and how to navigate that interview, that patient encounter effectively. From there, it was hoped that it would lead to more accurate information being gleaned from patients and ultimately a better informed diagnosis, which can help make sure we're initiating the most appropriate management strategies. So here is a close-up look at the intervention. So what actually was, or what is a mental health communication guide? In short, it's a handout that guides clinicians through the patient mental health interview, as I said. And the key component is that it offers suggested language and phrasing options. So if you or I were to go to our family provider and want to talk about anxiety or depression, and whatever mental health issue was on our agenda for the day, the idea is that our provider, our healthcare clinician, could pull out this communication guide or have it as a reference to help them walk through the interview to ensure that we develop a good rapport and to ensure that they're pulling on appropriate information from the interview and really maximizing their time with us to help inform a better diagnosis. And as Dr. Jessica said, why language? Why did we focus on offering suggested language? As she mentioned, the study from the Canadian Medical Association in 2019 suggested that 60 to 80% of patients are not forthcoming to their doctors. And this included a variety of reasons, including not wanting to feel judged, not wanting to feel lectured or embarrassed. So from that, it suggests how we conduct an interview, how we phrase our questions can make a difference in how patients, how comfortable they feel opening up to us with truthful and honest answers to help us inform our diagnoses and make appropriate suggestions. So as if we went into a provider and they used this communication guide, hopefully it would help direct resource referrals. In terms of how this communication guide was developed, I count myself very fortunate to have had time to learn from Dr. Josephus, as you heard from earlier. So we had the opportunity, a couple of medical residents, as well as a physician assistant, engaged in some group training sessions with Dr. Josephus, where she shared her expertise and phrasing that she had developed over the course of her career for conducting a mental health interview. And then when we created the mental health communication guide handout, we based it on another communication-focused intervention that already had some evidence to back it, in particular in the field of palliative care. So this serious illness conversation guide was developed, and there's a reference for it at the end here, but they developed it to help clinicians feel more comfortable having those really challenging conversations with palliative patients at the end of life. And so whenever we were creating the current communication guide, we pulled from some of the formatting and the idea of offering suggested language. And then of course, we tried to adapt the communication guide for the family medicine office context, which of course is constrained by time. We know that psychiatry interviews are great in that they have the opportunity to extend over a period of half an hour or an hour. Family medicine context looks a little bit more like 10 to 20 minutes. And then I'll leave this to Angela to expand a little bit further on the resource directory portion of things. And instead, I will bump into the next section on how the mental health communication intervention was actually delivered. So there were two phases that I undertook as part of this project and as part of my requirements for a quality improvement initiative as part of my residency training. And I wanted to pause here and talk about the term resident. I'm not sure if everyone is familiar with it, but especially when we watch American television, they're often interns on Grey's Anatomy, but in Canada, the equivalent term is resident. And so it means that the individual has completed their medical school training, they have their MD, but it's sort of like they have their G1 driver's license, so they need someone else in the car to drive still. So we still have supervisors or preceptors, but we're out in the clinical context, not just in hitting books. So the first phase of delivering this intervention was, as I said, learning from Dr. Josephus and actually trying to develop the content portion of this intervention. From that, a 1-hour PowerPoint presentation was created and delivered to a group of medical residents from the McMaster Rural Program. We conducted surveys afterwards to ask about feedback on whether the intervention was found to be useful, whether people felt that their mental health interview skills had improved as a result of being part of the presentation. And from that, we actually created the second portion of the current intervention, which is the handout. The handout and the PowerPoint were then delivered to a small group of clinicians, like practicing family physicians. Again, more feedback, and that's sort of where we're at right now, is learning how we can further roll this out and adapt it to meet the needs that providers are identifying. So I want to welcome you to medical training for a moment. When I asked Michelle what she felt would be useful to cover today, whether it was sort of outlining the process of the intervention or actually going into what we taught residents and family physicians themselves, she felt like both would be potentially interesting. So hopefully you agree, and we're going to pretend that you are a group of medical residents and family physicians who are receiving the training for the mental health communication guide and how to optimize your mental health interview. But because medical training can be stressful, I wanted to give us a minute to breathe first. I brought this part into the presentation because I think it's been a bit of a game changer for my practice to recognize that you can take the 30 seconds from your patient encounter to actually introduce some new skills that patients can carry forward with them. So I wanted to take this minute to do a grounding exercise together. Hopefully you can humor me here, and potentially you've tried this one before. It's called the 5 senses exercise. So I want you to take a moment. Here you can keep your eyes open or closed, and we'll just take a breath together first. Now I want you to, in your mind, think about one thing that you can feel right now. Like one thing you can touch. I want you to think about one thing that you can taste right now. One thing that you can see right now. One thing that you can smell right now. And one thing that you can hear right now. Great. Hopefully you're all feeling present in the room, and this is something, as I said, that I've employed with patients during the medical encounter, during an appointment, and found it to be quite de-escalating, and we'll go into that a little bit further as part of the strategies that we taught the medical residents and physicians. So here is a little excerpt. It's not the full presentation, but a sample of what was covered in the mental wellness interview communication guide for clinicians, i.e. checking behind doors with Dr. Josephus. I'm very verbose and I'm not good at coming up with short titles, but this was my leadership activity intervention that was delivered to residents and physicians. So during the presentation, I asked my colleagues to open the possibility of learning how to check behind doors, a metaphorical concept introduced by Dr. Josephus, which essentially refers to the idea of using questioning or phrasing to open a door and peek behind to see if a mental condition might be lurking there. And we'll go into some phrasing suggestions later. If the patient answers affirmatively to the question, it might mean you need to open that door a little further and step inside, take a better look around. If the question that you ask as you open the door is not applicable to them, you can close the door and move on to screening for another mental health challenge that they might be experiencing. We covered introducing some new phrasing for common questions to add to providers' mental health interview. I asked providers to think about how they could recruit unconscious data that is already on the table, available in the room for us if we pay attention, to help contribute to a more meaningful diagnosis. And finally, introduce them to the concept of how and when they could take detours into the social determinants of health. So here are some sample slides from the presentation, and I will say that the presentation, at least the second one, was structured based on the mental health communication guide, which was provided as a handout to participants so that they could follow along with the handout along with the presentation. So here is a sample of some of the topics covered in the presentation for providers. Providers were introduced to the concept of thinking before the interview even starts about the patient in front of them. Considering this concept of formulation that some mental health providers in the room might be familiar with, the idea of thinking about what biological, psychological, and social factors are at play in this patient's life that predispose, precipitate, or perpetuate their current presentation with whatever form of mental distress they are coming in with. Then I asked providers to also take a note out of Dr. Josephus's book and consider something that's not covered in the biopsychosocial grid. Just as we have topics, or just as we have factors that make us more likely to develop a mental illness or struggle with mental health, there are also protective factors, and it's important as providers that we consider identifying those. What are our patients' airbags? What are their sources of resilience? Dr. Josephus looks for five sources of resilience in her patient interview encounters. She asks patients about their family, about their friends, if they have furry companions. I apologize in advance if my furry companion jumps up on the screen here during my presentation. She asks them about their sources of faith or hope for a better tomorrow, and also about parts of their life that are filled with fun, laughter, and gratitude. I walked through with providers during this presentation the importance of going back to basics and getting some accurate demographic information on their patients. And it was sort of a bit of an argument or trying to convince them that this was important, because at least for family medicine, we often know most of the patient ID. We probably even know most of the history, but just as it's important to check in with new symptoms each time we see someone, it's important to recognize that their risk and protective factors in the form of their demographics may have changed. So for instance, asking about their occupation with respect to sources of income. As you can see here from the purple, the slides that I presented to the clinicians offered purple italicized language, and that was the suggested phrasing. So that's how it was demarcated there. As you can see, one option for asking about occupation is what do you do for a living, or potentially a less biased or more open-ended question might be, what is your source of income for those patients who are not currently working? As well as I said, when you're gathering demographic information, asking about their family. And then I introduced participants as Dr. Josephus so metaphorically and appropriately phrased it to the concept of reptile brain. This is the concept of recognizing when your patient comes in current mental distress, and remembering, just as she said, when she's feeling stressed out in a situation with, you can't remember the things that you can normally remember. This concept that our basic brain takes over fight or flight response, and that emotions hijack the logical mind. So when a patient comes in with phrasing like, I'm just so stressed, I'm just so overwhelmed, that it triggers providers' realization that they're in that reptile brain state, and this impacts how we may manage the rest of the interview. For instance, bringing in an opportunity for a grounding exercise like the one that we just completed to help bring the patient into the room. So the suggested phrasing, I can see that you're upset, I can see this is upsetting. What if we pause and do a breathing exercise together? I'm going to count to 2 as we breathe in, count to 3 as we breathe out. This also serves as a demonstration of the concept of recruiting unconscious data, or metaphorically put, the third eye. So recognizing what patients are bringing to the room and how you can use it to inform your diagnosis or your management of the interview. We went over how, basic language to just open the interview. How do you get to the point? How do you get them to speak about what they are there to speak about? So suggested phrasing options might be, are there specific concerns that prompted you to schedule this appointment? Or, I understand that you've been upset lately, is there anything I can do to help with that? We then went into exploring some possible presenting complaints that people might bring to the office with them, and how you might navigate asking questions around that. So this is sort of the concept of checking behind doors elucidated here. So if a patient comes in saying that they're upset or they haven't been able to turn their brain off at night, you might use a sample question such as, would you say that you're a worrier, or were you born worried? To open the door and look behind to see if anxiety might be at play for that patient. And then there's more suggested language at the bottom there to help move into stratifying what kind of anxiety might be at play. Is it a phobia? Is it based on social anxiety? For instance, checking behind the door for social anxiety, you might say something like, has anyone ever told you that you're shy? Or when you were in school, did you ever get sick to avoid tasks in class like speeches? We also spoke in the presentation about identifying these bridging symptoms or vegetative symptoms. And we call them that because they are present, or I should say they are upset and not present in a variety of different mental health conditions. The main symptoms we ask about are appetite, sleep, energy, and concentration. And we bring them up because they're the foundations of wellness. It's irregardless of what condition might be at play for a patient. If their appetite or their sleep or their energy or their concentration is impacted, those are individual things that we can address to help bring them back on to a path towards wellness, regardless of what condition they might be presenting with. This is just another example of checking behind the door for mood, and we can use it to move from one topic to another. So if someone comes in complaining about sleep, that they're not sleeping well, we can draw on that. So typically when people are feeling tired or sleepless, it has an impact on their outlook. How would you say that your outlook is today? Or how would you say that your spirits or your mood are today? And then about near the end of the presentation, we introduced clinicians to the concept of taking social detours. How do you move from your mental health interview into the social determinants of health? And more importantly, why? Why take the time to do it? So I included these slides because many of you, I'm sure, know and feel strongly about these topics as well, but just in case you're new to the field, the social determinants of health include things like access to safe and affordable housing, access to income, to food security, and we know that social determinants of health are the foundations for being healthy. So why ask about social determinants of health? Firstly, their prevalence. There's a statistic from Statistics Canada that 9.5% of Canadians live in poverty, and that was in 2017. So about 1 in 10 of people that we're speaking with are living below the poverty line. And as I said, that has a major impact on health. As we can see, as much intervention as we would like to do, our healthcare only makes up about 25% of what makes Canadians well or ill. And 50% of it is drawn from the factors in their life that we coin the social determinants of health. So as I said, income, disability, whether you have a social safety net, your race and sense of belonging. So we introduced providers in this intervention to the concept of thinking of poverty as a risk factor. So as a student, we are taught to do case presentations to our preceptors, to our teachers quite often. And you come and after you've met with the patient, you present why, what you think is going on, and you might list some of the risk factors that they have for a various illness. So this was introducing the concept of including poverty when you're thinking about risk factors for the illnesses listed on the right-hand side. I'm not sure if you can see them there, but diabetes, cancer, cardiovascular disease. So a student might say to their teacher, or a family physician might say to themselves, this patient that I'm meeting with has high blood pressure, they have diabetes, and they live in poverty. And these are all risk factors for cardiovascular disease. So it might change the investigations that you choose to do or how you might look into a condition a little bit differently. Finally, we introduced the suggested language for screening for these social determinants of health. This is evidence-backed language, 98% sensitive for statistics folks out there, for picking up people who struggle with income security. Do you ever have difficulty making ends meet at the end of the month? And that one is a great opening or checking behind the door question to look a little further. Same thing for food security. We offered some potential suggested language for checking into that, and suggestions about how and when we might detour to ask about food security. So for instance, when we're asking about reduced appetite. And finally, the last portion of this presentation, or the intervention that was delivered to family residents and clinicians, was about how to take this information and distill it down to digestible chunks to implement in family medicine practice. So here's a slide that I presented. This is a lot, the presentation was about 100 slides that I gave, so it was a lot of information. But I wanted to sort of provide some empowerment for clinicians and recognize the challenges and the strengths for conducting a good mental health interview in family medicine. Barriers to the mental health interview, as you mentioned, shorter appointment times, and we need to be able to set priorities about what to cover. But the benefits of having a family physician conducting a good mental health interview is that they already know the patient. They have a chance to meet with them frequently and assign homework tasks that they can follow up on. We have an intimate view of the link between mental and physical health. We see it all the time. And then finally, we have the opportunity for ongoing follow-up. So the last part of the presentation encouraged providers to suggest a take-home item, sort of similar to what Dr. Chisholm introduced. Potentially it's a handout, but in this case we talked specifically about teaching patients how to set goals and how to address one of the elements, for instance, of those vegetative functions that they might be coming in with. So suggesting some habits. We can't change everything. We can't change, necessarily some of those bigger social determinants of health, but there are certain small changes we can introduce to patients. And then obviously recognizing that we need to have resources on hand to suggest to our patients. So whether that's, we call it bibliotherapy, so developing a list of things that we feel that are vetted, that we have tried ourselves, and that we would recommend to our patients. So this comes into play, whether it's the resource guide that you hear about, or basic, TED Talks. I have the Headspace app there. There's also Insight Timer, which is a free meditation app. And then the Happiness Lab is one of my favorite podcasts that I will sometimes recommend to patients. And so from drawing on that, I thought our brains are probably pretty full. I thought we would take a moment here to indulge in some mental wellness practice ourselves, drawn on one of the podcasts from the Happiness Lab. So in this episode of the Happiness Lab, Dr. Lori Santos is a professor of psychology at Yale, and she interviews in one episode Ross Gay, who is a poet and a writer, and for 1 year, I don't know if anyone has heard of this book, but for 1 year, he notices delights, one per day, and it inspires him to write something about that delight. And so it's a book of delights. So for instance, I hope that we can take 1 minute to turn to the person next to you, or if you're at home watching on live stream, take a moment to think to yourself about one delight that you've experienced in the past week. And some example delights can be big or small. Taking a sip of coffee that's just the right temperature, or a sip of non-decaffeinated beverage that's just the right temperature. I watched someone walking about 10 dogs the other day, and I thought, delight. And in this book, in the podcast, you actually are technically supposed to put your finger up in the air and say delight. So you're welcome to do that as well. But I thought we would just take 1 minute to share in a delight with your neighbor and let them know something that delight you've experienced in the last week. So we'll take a minute for that. Great. I think that's been about a minute there. I heard some laughter, so I hope I'm having some FOMO over here. I hope that everybody enjoyed sharing delight with their neighbor. So just as I head into the last portion of my presentation here, I just wanted to go over actually looking at the handouts, I should say, themselves. I haven't introduced them clearly yet, but I wanted to zoom in on what the actual paper portion for clinicians ended up looking like based on the feedback from the initial presentation to residents and then from feedback from the family physicians who received both the PowerPoint and the handout. So as you can see, we actually created 2 documents. The first one was the mental health communication guide itself, the one that's intended to kind of guide you through the interview as a clinician. And then the second document was, if you can see the title there at the top, it's the accompanying reference document for clinicians. So sort of walking them through some of the key takeaways from the PowerPoint that will allow them to use the mental health communication guide effectively. So for instance, on the mental health communication guide itself, in the top left corner, there's this setup black box. And so it sort of goes over the things I introduced in the PowerPoint presentation, that before the interview, think about the biopsychosocial formulation, think about your patient's resilience factors, set a time frame for the appointment. Sometimes that can be helpful, suggesting that you take the next 20 minutes to talk about XYZ, and then remembering to use your third eye. Then, as you can see, the communication guide includes some of that suggested language. It doesn't include all the samples of the suggested phrasing, but it does have a few, and it's structured as how you might flow through the interview. So starting with patient ID, moving on to the presenting complaint, asking about some of those vegetative or bridging symptoms, and then checking behind the doors for mental distress. So some of the phrasing for that, checking for worry, checking for social anxiety, checking for OCD. There's just a sample there, but it does go on to a few more conditions that we might consider checking for. And then also the phrasing for checking behind doors for the social determinants of health. We conclude the mental health communication guide handout with suggested resources. And so these include the resource directory for mental health services that you'll learn about, as well as links to the poverty tool on the Center for Effective Practice website, which I don't know if anyone has used that before, but is an excellent resource, as well as the links to some of the other resources for the social determinants of health, like the Ontario Social Assistance page, and 211, an excellent resource. And the last part talks about reminding the clinician to set up some homework or behavioral prescription for the patient, and then setting follow-up and referrals. And then just a brief foray into the mental health communication guide reference document for clinicians. As you can see, it includes a picture of the mental health communication guide right on there to remind clinicians about what to do, and it goes through sort of what the prompt means and what they can do to fulfill that prompt before the interview. We talk about why it's important to explore the presenting complaint, etc. And then we even give some strategies for common scenarios. So the patient who comes in with rapid or over-inclusive speech who's difficult to interrupt, for instance, this might be something we can pick up on from our unconscious data that can help inform our diagnosis. Are they anxious? Are they manic? Are they, how can we direct this interview? Because we're going to lose valuable time if we don't kind of set some structure to the interview, and then some suggested phrasing to try and there's a few more strategies as well. And then finally, focusing on the social determinants of health, reminding clinicians why it's important to ask and how they can implement that suggestion. Okay, you're done. Medical training, well done. So I wanted to just conclude with what we gathered for data and feedback. So this is still in the early phases of this intervention. We haven't rolled it out to many providers yet in terms of the communication guide itself, but my quality improvement project in residency wanted to assess the interest in and impact of mental health communication guide in primary care. So in particular, I was interested in whether residents and family physicians were even interested in improving their mental health interview. Did they care about improving their ability to inquire about a variety of mental health conditions and social determinants of health? And then was there an impact of this communication-focused intervention on the provider's perceived competence and confidence in conducting the mental health and social determinant of health interview? So as you can see from the numbers, they're small. These were the initial results. So the first bar in each column is resident responses, and the second bar in each column is physician responses. 100% of participants said that they were interested in improving their ability to inquire about a variety of mental and social determinant of health conditions. And the majority of participants ranked this as about a medium priority on their list of things to do. As you can see, let me just pull up my statistics here. So yes, 87% of residents perceived that their mental health interview and ability to ask about those two, kind of the mental health and social determinants of health factors impacting patients' life, improved as a result of the intervention. And both of the doctors who completed the training felt the same. 100% of providers felt they were more confident in conducting a mental health interview and asking about the social determinants of health. And then both the physicians and about 76% of the residents said they would be likely to return back to the mental health communication guide if it were available to them in the future to use to help direct their interview. So in summary, COVID-19, as we know, has had a plethora of negative mental health consequences that have been demonstrated at a national and a local level. And this, despite the need for increase in mental health care, our pre-pandemic demand for psychiatry and specialist mental health care already exceeded the supply. So given their frontline roles, their pre-existing relationships with patients, and the fact that particularly in rural Ontario, providers are trained to be generalist providers and provide care across multiple domains, family physicians or frontline mental health care providers have a lot of strengths in opportunity for being resources in delivering the mental health interview. And they are well positioned to help address the current surge of mental health demand. That being said, with support. So initially, the early data suggests that providers are interested in improving their mental health interview and helping to meet the needs of their patients. And there is some, again, early data to suggest that this kind of upskilling intervention where we focus on broadening and honing the skills within a specific area of family medicine can be effective meeting the need for mental health. And as I said, they need some support though. We can't just add another thing onto their to-do list without proper support. So the areas of identified support might include things like accessible, accepted, and available resources. And by resources, I mean a couple of things. So resources in the form of, handouts.ca or a communication guide that's available, the resource directory guide that's available, and then of course actually having those resources to be available for patients, having well-funded community resources that can do the variety of jobs and roles to help in a multimodal way meet people's mental health needs. And then of course having adequate training opportunities to build on their skills. And whenever I was reading through this Rural Ontario Municipal Association document, this seems to align with the suggestions from ROMA and their calls to action for community-based mental health solutions. So next steps, again, me being very happy about myself here, climbing up this hill, some future steps include rolling it out to more providers. That would be the first main step that I can identify, making sure this communication guide is accepted and meeting a need that providers see and rolling that out in an accessible way. One thing that I'm working on right now is integrating the interview into the electronic medical record that's currently shared by providers in the Collingwood, Muskoka, Stainer region by our family health organization. So creating a stamp of essentially the mental health handout, but not quite as thorough, but potentially more easy to use and implement during real-time patient encounter. And then looking at potentially other upskilling interventions in the future for residents or for family physicians who are going to go into practice frontline in rural areas, and offering those training opportunities to them to help meet the mental health care needs of their patients. That's all that I had. And I thank you for your time listening today. Again, I apologize I can't be there, and I appreciate your attention. And if anyone has questions, myself and hopefully Michelle will help me to field them. Thank you.
Thank you so much, Dr. Joy. I see we have a couple of questions already, so.
Thanks, Dr. Joy. My name's Sarah Grace. I'm from the South Georgian Bay, Ontario Health Team. So it's really great to learn about this project, and congratulations to you and your team for this work. There's just a few kind of opportunities, I think, more than anything else that have sparked in my interest when listening to this. The first of which is one of the leading projects through the Ontario Health Team is a collaborative electronic referral process with 211. I won't bore you with the details. There's lots of information about it on our website, but essentially it's enabling an electronic referral to be sent to 211 from the primary care EMR as well as the community, and then facilitating a feedback mechanism to the primary care provider with the outcome of that referral. And it's all includes the patient in that referral process as well. So I think there's lots of opportunity to perhaps connect that as an outcome resource to support patients and physicians depending on what was uncovered during that conversation and that additional communication guide. So I'm more than happy to connect with you offline around that and perhaps integrating that tool into your resource. And then I was glad to hear that you'd like to integrate it into the EMR. I think there's a lot of great opportunity to do so. And we have a few kind of innovative ways that we may be able to add that into existing toolbars and make it really like an integrated tool that can be educated and presented to the family physicians as well. So more than happy to connect about opportunities around that, and OHT is more than happy to support that.
That's so wonderful. Thank you for sharing. And that's so interesting. At the OHT meeting the other night, a few clinicians were talking about how nice it would be to be able to initiate a referral to a group like 211 and actually get feedback back of what came out of it. And half of the time being, I'm not new to the area, but newer to the area. Half of the time it's just such an iterative learning experience to see what resources are out there. I always learn from people coming back to me and saying, oh yeah, they referred me to this service. So thank you, that's really great. I'd love to connect about that. Thank you.
Yes, that's great.
Any other questions? Dr. Josicas has a question for Dr. Joy.
Jodie, I just wanted to say that you did a spectacular job. I didn't realize that we had spent so much time together and that you had incorporated so many of our discussions. So I think you've done a fantastic job. But I do have a question. What is your hypothesis as to why the students weren't 100% sure that they were going to use the guide? Because I find that surprising.
Yeah, that's a great question. I think I can't confirm, I would have to go back, but the first round of delivering the intervention didn't include the handout. The handout was developed as a product of the first, like the feedback on that first presentation. So a lot of the feedback that I got from residents in that after that first PowerPoint session was that they wished that there were a handout. So I think at that time they felt that it would be having access to the resource would mean having access to the PowerPoint, which flipping through a 100 slide PowerPoint probably isn't that accessible. But hopefully if we were to run this with students again, they would feel a little bit more, that they would be interested in referring back to something in a more kind of compact, accessible format.
Okay, we have another question.
I'm just from the Kincardine Family Health team, and I was wondering if this training is accessible now to get other people trained in our area, like our physicians and nurse practitioners in family practice, and who do same-day service with people who don't have family practitioners.
Great question. It's not currently. This was sort of a project that came out of ROMP and the hospital and my need for a quality improvement project. But I think, and I'm going to ask Michelle to step in here and Dr. Joskus as well, that would be the hope is sort of transplanting this training because it's not specific to, other than the resource directory part, the actual communication piece is not specific to South Georgian Bay. I think that would be a great opportunity moving forward. Not that the infrastructure is currently in place right now, but again, I'm happy to connect and work with ROMP to help deliver that if the intervention is felt to be interested and valuable for people.
And again, the work today is being shared, and it's really in the context of the opportunity to scale and spread. And those were all parts of what our grant was set up to do. And so what are our next steps? Today is a big part of that, and having this presentation, handouts.ca presentation, Dr. Joskus, to mobilize where we go next and what is the interest and the uptick that we can go from there. I think, Gaynor, you had a question.
Just a quick question about what EMI is. So with working with Dr. Joy to incorporate the tools into the PS Suite, if we connect, we're always happy to share the tools. Yeah.
Just another question.
Thanks for the presentation, really excellent. One of the things I'm wondering if you saw any reluctance about going into social determinants of health from an interview perspective in case that actually came forward and then not having the tools to manage social determinants of health, and then from a clinician perspective, then knowing that that's going to add more time to a community that's already stressed for time. Just curious.
Yeah, that's great. And I as part of the presentation that I gave, I had a slide on what might stop you from asking about social determinants of health actually, and then gave it a chance for people to respond. I got a lot of time answers back. One of my personal answers was, what if they bring it up and I don't know how to help? I don't know what to do. So I think that part of the solution for that is having some of those resources on hand quickly to know that you have the referral to 211, to know what website the poverty tool is on, that you can help direct the patient to ask about, did you file your income taxes? What benefits might you be available to? What resources do we have in our family health team or in our group to help you navigate those kind of social challenges? And I agree that it adds a little more time when you ask that, but it takes some of the stress of the provider away. If you feel like you have resources to kind of follow up on that and someone to turn to, so that you're not opening a book that you just want to close as soon as you open it. So yeah, I think it definitely speaks to reluctance of addressing topics that we're not comfortable with. As providers, we like to have the answers, which we often don't, but it is helpful to have that kind of resource base established and know you can refer to.
Got a follow-up question to the previous question. I haven't heard anything about ACE scores, and I live in Bruce County, and I'm originally from London, and I can't get over how many people come through the office, and once we do an ACE score on them and start connecting the dots, that we get to a different chapter in their life. So, and I know that's usually in a second or third or fourth mental health visit. It's certainly not in the first visit, but I wonder if you could comment.
Yeah, that's great. Actually, that's not something that I had incorporated into the tool before. So that is a really excellent suggestion, and definitely requires a little more looking into it on my part of how we kind of check behind that door. And when you do it, as you mentioned, it was this intervention. I feel like it was, at least from my part, trying to get buy-in from providers that we can do some of this work in family medicine in shorter appointment times. So initially kind of focusing on what if, I remember posing this question to Dr. Joseph, if you said that we had to cover, like, what are the most important things to cover in the first appointment? Like, what do we have to get through? But I could see that would be really elucidating. I don't know if that's a part of, like, doing these scores is a part of many individuals' practices that I've been a part of, but that's great. Thank you for bringing that to my attention. It definitely requires some more research and potential integration into this tool on my part to help address that. It's probably as you mentioned, for sure.
Yeah.
Thanks.
We use PS Suites as well at Sauble Beach, and we have the Ocean Tablet platform that connects to PS Suites. So on there we have the GAD-7, the PHQ-9, the ACE score. We also have a poverty score, because there's lots of poverty. We're wedged between two large First Nations communities as well. And our mental health coordinator, who's a social worker, also dovetails with all of the mental health services in the area, which certainly helps out. But there's a huge need, and like you said, it took multiple in-services at our office to get us all up to speed, so that we would learn how to do it a little bit better. And one thing we came up with is we have wraparound appointments. So I will see the patient at the same time the social worker is seeing the patient. And those wraparound appointments continue on forever. So when the patient rebooks, they're usually rebooking with both to either manage medications and or get the mental health coordinator to share information on the chart.
Wow, what a wonderful model. Wow. Yeah, that's incredible. Yeah, I would be interested in hearing what we have Ocean as well, and hearing what might potentially we already have them, and I just don't know what poverty scores and ACE scores that you use, so that I can start implementing that as well. That would be great. I should have left my email. I didn't. I don't think I put it on the slide, but I can maybe send that out through Rob somehow. But thank you for sharing all of that.
That's great, Jodie. We can actually share that with those here that in the group that have that as of interest. So I think from here we're going to be moving on to Angela, who has developed the handouts as you had mentioned. Thank you for taking your time. Thank you for extending that conversation about the power of relationships, and who is really best positioned in our communities to, as Dr. Joseph said, maintain long-term relationships in our community. And again, that's based off of a lot of the work that Barbara Starfield has done in primary care as the #1 contributor to population health in our communities, as we are working towards long-term relationships with family physicians and primary care providers with our community members.